I'm Kate O'Brien, and I'm a master's student here at the University of Calgary, and I'm also a member of the National Bobsleigh program. I injured my knee learning that I should not do hurdles. That's the main thing. I tripped on a hurdle when I was in high school doing track and basically tore most of the structures in my knee, or at least injured them. And then since I've had 3 reconstructive surgeries to try and correct what had happened. I'm fairly fortunate in that it doesn't impact it nearly as much as it could for a lot of people, especially with such a significant injury. But there's not really a day that goes by where I don't know that I've done something to it. It's always kind of there in the background. It's not always excruciating. It has bad days and good days, but it's always just there, and it hurts when it rains. I'm lucky with the team because we are given a lot of therapy, I guess. So if something's really bothering me, I can go and get it seen to by one of our team therapists. As well, I actually think, although training is sort of a double-edged sword, in that you're putting your body through so much all the time, it strengthens all the muscles around that joint. So it aids in a way in making OA or pre-OA, in my case, better. At least that was my experience with it.
I'm Roman Krautz. I'm a scientist in the McCaig Institute for Bone and Joint Health at the University of Calgary. We've recently published a study in the Journal of Rheumatology that describes a potential new way of diagnosing patients with osteoarthritis. And why we're excited about this is because typically osteoarthritis is clinically diagnosed through pain and potentially the loss of joint space in the knee. And these types of clinical diagnoses are only accurate in patients with more severe stages of the disease. And with most diseases, you want to try to catch them earlier so you can apply effective treatment. Our diagnostic uses blood, so we can either use synovial fluid, which is found in the knee joint, or we can use the serum, so part of the blood that's very easy to obtain. And with a very high level of accuracy, we can predict which patients have osteoarthritis and which patients don't. As of today, to the best of my knowledge, there are no diagnostic tests approved for use for osteoarthritis. We're planning on providing this diagnostic to physicians in Alberta as a research study, and that we could get information on the benefits that the physicians saw in helping to diagnose patients, if the patients saw any benefit of getting an earlier or more effective diagnosis, and what happened to these patients as they move through the healthcare system. So did they see an orthopedic surgeon sooner? Did they see a rheumatologist? What was their outcome? And so we're planning on carrying that study on for the next 5 years. And at the end of that study, collaborating with health economists, we'll have a much better idea if this study helps patients, if it's cost effective, and if once we have that information, then Health Canada, FDA, that's something that I think will help sway their minds to allow this to become a licensed diagnostic for osteoarthritis.
I'm Marvin Fritzler. I'm Director of Mitogen Advanced Diagnostics Laboratory. Within osteoarthritis, we're talking about more than one condition. And along with that is that when you come to treatment, that one size does not fit all. And so that goes into the personalized medicine side of things. To do that, you have to put patients together. Like I like to use the metaphor of a mosaic or a painting that's a mosaic, because each piece adds a different part of that patient. So we used to think if you had a diagnosis of osteoarthritis, that tended to track you off into a certain category of treatments and outcomes and that sort of thing. But we know that isn't true. So the name of the game, as I see it, and what Dr. Krawetz and I have been doing together, is trying to break osteoarthritis down into meaningful clinical subsets. And then following on that, what's the appropriate treatment that follows? Our approach to personalized medicine is using multiplex technologies. What that means basically is that with a single pinprick of blood, we can identify up to 1,000 different components in the blood within a very short period of time. Within minutes, you'll have this very, very complex mosaic, as I referred to it before, of the patient. And then each patient is different. But we're able to categorize them based on certain of these, we call them biomarkers in the blood. They can be things like proteins that degrade collagen in the joint, or antibodies and that sort of thing. So each patient then gets their own unique picture on a single fingerprint of blood within minutes. You can put this together. And what we've been doing with Dr. Krawetz in the Osteoarthritis Project is then asking the question, okay, does this subset patients into a meaningful group of people? In other words, are there some in there that are very fast progressors to severe disease, or are there the more slowly smoldering patients that? Obviously, for any of those two categories, treatment is very, very different. The advantages of multiplex not only giving this complex picture very, very quickly, but it also is a lot cheaper than conventional technologies.